to the demo.
This was really good. You now know your workhorse, the scanner, and which buttons you can press. And I think it's time that we show our users what you can do with this machine, right?
Yes, and we will start to image with the parasternal approach. You are familiar with it because when we talked about the left ventricle, you've seen the parasternal short axis at the level of the papillary muscle. And when we talked about the aortic valve, you've seen the parasternal short axis at the base and the parasternal long axis. Now, we will start with telling you more about the parasternal long axis view. You already know this view because we talked about it in the introductory course. But now we would like to go really into details and teach you more about this view. So just for you to remember, when I want to perform this view, I ask my patient to really turn on his left. So his arm should stay under his head, and my transducer goes in the second, third intercostal space near the sternum on the left part, and the marker points to the right shoulder of patient. So this will be the image you get when you play a little bit on the chest. I recommend once you see where the transducer is, just focus on your echo machine and the image you have and adjust it. So don't look at the chest of your patients again. How should it look like? It should really well show you the aortic valve and the mitral valve together with the ventricle. So you will have the inflow and the outflow of the left ventricle. So the leaflet, which is really close to the aortic valve, will be named the anterior leaflet. The other one will be the posterior. You see really good these two valves. Remember, when you have a parasternal long axis view, consider the aortic valve and the ascending aorta all together. When you want to focus a little bit on the ascending aorta, what I can recommend, go a little bit up. Maybe you lose the other structure, but you definitely see the wall. And when you want to go back, you just go down one rib and you have your image again. So consider aortic valve and ascending aorta together. When is parasternal long axis view not a good view? When you don't see the aortic valve, for instance. Your transducer is tilted, is rotated, you lose the aorta or you cut the ventricle. Then make sure you see all the structure in one view. Make sure your ventricle is not cut like here, and that you don't see the right ventricle. In a good parasternal long axis view, we only see a part of the right ventricle, and it's a right ventricular outflow tract. So to better understand the anatomic correlation, we will give you more examples using our simulator.
But before we go to the simulator, here are the key points that you should remember from this demo. First of all, try to see the separation of the aortic valve cusps. Display the aorta in its full length. Try to avoid an angle between the septum and the aorta. And see that the apex is not closed, neither on the one or the other side. And remember, you can only see parts of the right ventricle, and you will not see the left ventricular apex. Okay, and now let's go to the simulator and see how all this corresponds with anatomy.
In the starter kit, we gave you an idea on the structures which are shown in a long axis view. Now we would like to go more into details, with the advantage that we are using the simulator and we can really focus on the anatomical correlation. So the long axis view, as you can see, shows us a part of the right ventricle, only the outflow tract, interventricular septum, left ventricle with inflow across the mitral valve and outflow across the aortic valve. And this is the structure we are really focusing on. In addition, I can tell you this round structure here is the descending aorta. And this small round thing just behind the left atrium is the coronary sinus. What you can also appreciate, and I told you, with a slight rotation of the probe, you can better visualize the ascending aorta, and you can see the anatomy really helps you. And now I will show you what happens when we tilt, rotate, and move the transducer. So actually, to have an optimized long axis view, you have to see the ventricle really on its length. So a rotation of the transducer like this, when you look at the anatomical correlation, really shortens the ventricle. This is not what you want. So again, you go back with rotation and make the ventricle longer. And this is also for the aortic valve. So actually, rotations, really small rotation, you see, and maybe now you understand why we don't have the aortic valve in the view, simply because we are losing it with these small movements. Use small movements to get the aortic valve again.
I'm sure this helps you understand the anatomy and topography better of the parasternal long axis view. You see, what we try to do is we try to show you not only the correct view, but also the incorrect views and how to get to the correct views from these incorrect views. So we have a number of views installed for you that show you both the correct and the incorrect.
Yes, Thomas. And here, for instance, is the same patient, imaged from different levels. So from top to the bottom of a parasternal long axis view. And you can see in the first loop, you can really well visualize the ascending aorta, and going down with the probe, the transducer, you reach another level where you see the ventricle more. And if you notice, actually, the position of the interventricular septum is also different. This is not a bad view compared with the other one, but it's only another possibility of imaging the heart.
So the position of the septum changes, and also the position of the aorta. Look at the aorta here, and look at the aorta here. Now, actually, if you look at the guidelines, this would probably be the correct view that you should acquire. But the advantage of this view, for example, is that you see more of the aorta. And maybe in this view, you see the echogenicity better of the septum. And maybe in this view, you would see the mitral valve. So the key message here is, yes, the standard view is probably the best view, especially if you want to measure. But if you want to look at different structures, don't forget that the atypical views can be just as good sometimes.
And how does rotation affect the image? Well, we have two images on the top and left. We have an image where the probe is rotated counterclockwise. On the right, the probe is rotated clockwise. In both images, actually, we cannot see the aorta in its full length, and the ventricle is closed.
Yes, that's completely correct. And the correct image, again, would be on the bottom. And if you have the views here on the top, all you need to do is you need to rotate either clockwise or counterclockwise to get to the correct view. So knowing the wrong image is very helpful to know how to get to the correct image.
And now let's go back to standard views and let's see some examples.
Here's a parasternal long axis view where the mitral valve looks kind of awkward. There's a strange motion of the anterior leaflet. You'll find out later that this is mitral valve stenosis.
And here, for instance, is a good parasternal long axis view, but this patient has dysfunctioning left ventricle.
Yes, function definitely is not normal here. We can study left ventricle function from a parasternal view, even though there are better views. But again, an advantage of the parasternal view that we can see parts of the ventricle at least.
And here, for instance, I'm sure you notice the thickness of the myocardium is extremely increased. So this could be a case of hypertrophic cardiomyopathy, for instance.
Yes, a very important disease that you should know, especially if you work in acute care settings, because these patients can evolve sudden cardiac death. And here's an example of an operated heart, a parasternal long axis view, where the aortic valve prosthesis is nicely visible. You see these echogenic structures here, these artifacts. That's the artificial part of the valve. And here, even on the mitral valve, you see that there is a little echogenic area here and here, which is the annuloplasty ring. So in summary, a patient who has been operated both on the aortic and the mitral valve. And now let's go to some color Doppler studies.
Yes, you know about color Doppler already, and here, for instance, is a completely normal study. So, as you see, we have no turbulent flow, not on the aorta or in the mitral valve.
So the parasternal long axis view is a view which you can use color Doppler as well, especially to document eccentric jets. As you can see here in this example, this is a patient with an aortic valve pathology. This greenish color here is a jet, that's aortic regurgitation, pointing downwards towards the anterior leaflet. And I guess you will agree, Anna, there's also some degree of mitral regurgitation.
The same jet, smaller maybe, representing mitral regurgitation.
Yeah. And an example of a true mitral valve pathology, the mitral valve again looks awkward, it's very thickened, and it prolapses. This is your very first mitral valve prolapse you've seen. You're going to see a lot of them in the chapter on mitral regurgitation. So in summary, there's a lot of things you can do with the parasternal long axis view, but now we need to move on to the next important view.
And this is the short axis view. As you can see, it's not only one view, but several views. It depends on how and where you cut the ventricle. How do we get to this view? Well, we start with a parasternal long axis view, and then we slowly rotate clockwise until we get to the short axis view at the base.
Yes, that's exactly what we should do. And if you look at this view and this view, we've seen these already when I showed you the false views of the parasternal long axis view. So we come across these false views on our way to the short axis view. And this short axis view is only one of the potential views we can see at the base here, but there are other short axis views as well. We already showed you some parasternal views. We showed you this view, and this view. How are these views actually connected? Well, let's start out with the parasternal long axis view to give you a better understanding. Okay, this is the parasternal long axis view, and now this here would be the midline of the sector. Let's bring the aortic valve now into the midline, and then we start to rotate clockwise. And by doing so, we will get into a short axis view. This is the view that we introduced to you to show you how to detect the aortic valve stenosis. Now the marker is pointing to the left shoulder, and we are now transecting the aortic valve. But if we tilt the transducer now downwards, we will eventually come to a position where we see a structure which looks like a fish mouth, opening and closing. This structure is the mitral valve with the anterior leaflet and the posterior leaflet. And if we tilt further down, we will eventually see only choroidal structures. So you see that the mitral valve is actually interrupted here. Those are only the choroidal structures. And if we tilt down even further, we will see the papillary muscle. So this is the heads of the papillary muscle. And going down even further, the ventricle gets smaller and smaller and smaller, and eventually we will lose the ventricle. We cannot always see the very apical portions. So essentially, by performing such a sweep from the base of the heart down to the mitral valve, down to the ventricle, down to the apex, gives you a full appreciation of the entire heart. However, remember, we have to follow the axis of the heart, the base and the apex. So we are now perpendicular to this axis and tilting up and down.
So we sweep through the entire heart.
That's completely true. And let me show on the model which structures we meet. We start here at the level of the aortic valve, just a little bit below the great vessels. And then we sweep downwards. We hit the mitral valve and the more medial and distal parts of the septum.
But isn't it sometimes difficult to hold the image?
Yes, that's certainly a problem. You can either change or misplace the rotation, or you could sometimes lose the position on your axis of the heart. So the tip that I would like to give you is stay, first of all, in the axis of the heart. Try to be perpendicular to this axis. And second of all, rest your arm firmly, and especially the hand firmly on the body, so that you don't tilt neither in this nor the other direction.
And this is what Thomas just said, the standard views which you should record when you want to perform a standard exam. So, the parasternal short axis at the base of the heart, at the level of the mitral valve, at the level of the ventricle, so somewhere in between the mitral valve and the papillary muscle and the papillary muscles itself.
But remember, when you do the sweep, don't forget that you have intermediate views as well. And just as I mentioned before, look at them as well, because they could display some form of pathology as well.
Yeah, that's completely true. And to make you better understand the anatomy, let's go back to the simulator.
We have the left ventricle here, round, and then we have the right ventricle right here, and this would be the diaphragm. If you tilt the transducer just marginally upwards, you will see the mitral valve, or at least the tips of the mitral valve. And if you tilt it down, you will see the papillary muscles right here. So try to see that the ventricle is round, somewhere between the papillary muscle and the mitral valve.
So keep the ventricle round.
Yes, and as a matter of fact, keeping the ventricle round is probably one of the most difficult things in echocardiography, and that's why I see people having the most problems. But remember, echocardiography is not much different than a computer game. For example, like an ego shooter game where, let's say, the alien is coming towards you, and you have to fine-tune the motion of the joystick to avoid you getting shot. And what we're going to do now with the simulator is show you exactly which fine-tuning you have to do to get the optimal views.
Here are a few very important tricks that will help you to optimize the image so that you get a very good short axis view. Now, in this case, we have a short axis view, but it's not really in the middle of the sector. How do you get it into the middle of the sector? Well, by performing kind of a rocking motion. So you move the transducer more towards I would say to the right shoulder in this case, and optimizing the image so that you have it right in the middle of the screen, okay? And then when you have it in the middle of the screen, you would optimize the rotation. See what happens if I rotate counterclockwise. All of a sudden, I would leave the round shape and come into what will then be a parasternal long axis view. So try to optimize the view so you have the ventricle as round as possible. And the next thing you have to correct is the level where you cut through the left ventricle. This is optimal, but if you are too far low, you will have a view which is something like this, in other words, oval, and this is not the correct position, at least not if you want to measure.
Well, thanks, Thomas. Now our viewers know not only how to image the heart, but also how to get high scores at computer games. Now let's go back to the most important things Thomas just said. So remember, when you have a parasternal short axis view, get the aorta into the middle, correct for roundness, optimize the level of the transducer, and avoid the oval ventricle.
And relating to the shape of the ventricle, oval is only one thing that changes when you change the position of the transducer. Here is an example of what happens if you place the transducer at different positions on the chest. If you have it very far cranial, you would have a relatively large right ventricle. But see what happens if I image further down. The right ventricle gets smaller, and if I put the transducer relatively close to the apex, the right ventricle will be very, very small. So keep that in mind as well. And if we now come back to the rotation, let's show the same thing we did for the short axis view at the base. Here is the ventricle in the middle. This is the optimal view. And here we are rotating counterclockwise, and all of a sudden the ventricle has a shape which looks like this. Now we're almost turning into a parasternal, I think, long axis view. And the same thing happens only in the other direction if we rotate clockwise. And if we now come back to the standard views that we want to show you, then we have the base of the heart here with the aorta as a central structure, left atrium, right ventricular outflow tract, tricuspid valve. Then further down, we are imaging at the level of the mitral valve. This is the fish mouth of the mitral valve. Here we are at the level of the ventricles between the mitral valve and the papillary muscles. We see still some chordal structures here. And then finally, this is only the ventricle. Here are still some parts of the papillary muscle visible. So different levels in our tilt and different images.
And here's some practice tip, which applies not only for the parasternal view, but to every view. So practice on different patients. practice the sweep, optimize to the structure, learn to hold the image, and learn off images and how to correct them.
Thanks, Anna, for these practical tips and for the summary. But I think it's time that we really practice and now go to some case studies that will help you in your daily clinical practice.
Yes, and this is the first example. We have a color Doppler study showing a structure we haven't talked a lot about. It's the pulmonary artery. And here we have pulmonary regurgitation.
Yes, this is pulmonary regurgitation. And now compared with this image here, you see that there's a lot less pulmonic regurgitation in this patient. And this is also a patient where we have a normal-sized pulmonary artery. We always compare it to the aorta. Now, how do we get to this view in the first place? Well, actually, one tilts the transducer a little bit more ventral and turns towards the left shoulder. And by doing so, you will get a better appreciation for the pulmonary artery.
Yes, and this structure actually can reach really huge diameters. Still in this picture, for instance, compare again the pulmonary artery with the aorta. So it's massive dilatation.
Actually, this patient had rupture of the pulmonary artery, a patient who had massive pulmonary arterial hypertension.
And as you can see here, we have a parasternal short axis at the base with a very calcified aortic valve, and this patient actually ended up to have also endocarditis. And here the same image, same level. This aortic valve is also calcified, especially along the rim, so we would talk about aortic sclerosis with maybe some degree of aortic stenosis, not really severe.
I think some part of the valve is still opening. Of course, we cannot say definitely how severe it is, but we will learn in a future chapter of exactly how to quantify aortic stenosis. And in this patient here, we have a cut plane now at the level of the ventricle. Anna, what do you think? How is left ventricle function?
Well, it's reduced, it's very reduced. And if you look just for comparison purposes, this is a normal ventricle.
Right. You see, these are the things that we taught you already in the starter kit. I'm sure you all recognize the function already from the short axis view, and you probably also know that this patient has poor left ventricle function. See, we have, again, a very thick interventricular septum and poor left ventricle function. These are just some examples of where you can use the short axis view, and now we've got a question for you. At which level of the ventricle are we now cutting the short axis view?
Well, at the mitral valve level.
So you see, it's not so difficult. So this concludes this chapter on the parasternal window. And next on our list is the apical window, which I think you will agree is probably the most important window in echocardiography.